Bismillah ar-Rahman ar-Rahim. This presentation about data management. Data management is a very long journey. It will take 3 or 4, even more than 4 presentations. So we will start today with part 1. Then we will continue inshallah in the next few weeks to complete the whole informations about data. Why we are giving this presentation or preparing it or introducing it, simply because it's your choice. As you know that we make a Google form to check what's the highest 5 priority areas to give you presentation through, and your first choice was Sibahi interview question and answers, and I believe we finished it a month ago. Then number 2, which is your second choice, was the data management, and it constitutes 24% of your choice, so it will be today inshallah. Again, why? Because it's more than one standards inside Sibahi. We'll talk about data management. I'll give you only 1 or 2 examples about it. So here in the leadership, number 31, standard 31 is talking about the department head ensure performance measurement and improvement of the outcome of the department. This means that the head of the department ensures that they are doing improvement, but they cannot do improvement without data. So as you see here in leadership 31.4, performance measurement and improvement involve regular data collection, analysis, and appropriate improvement and action plan, and even how to report those data. So every single head of the department and his staff inside the department should do regular data collection, analyze those data, report those data to make improvement or to help the leadership to have decisions through those informations in. And we have to give some concept first about data, which is DRIP. DRIP means data rich information poor concept. This is about what? About that we have a lot of data inside our healthcare facility, but the problem is we cannot take a good use of them. So we have data rich, a lot of data, but the information are poor. As you see in this example, the secretary is asking her boss that I hate to ask again, but what is I'm supposed to be looking for? We have a lot of data. I have a lot of data, all those documents containing data. But the problem is I don't know what I'm searching for, what kind of informations we are searching for. So at last, all those paper will go through the shredder, and we did not get any use of them. Another concept is DDIC, data diarrhea, information constipation. We have a lot of data, but the problem is we have a few informations. Who's collecting data inside the healthcare facility? Nursing are collecting the informations and data. A lot of departments are collecting data, like medical department, ICU, ER, OR, OPD, all of them are collecting data. A lot of programs inside healthcare facility also are collecting data, like ADA program, like clinical audit program. Also statistics department, MOI, and the statistician inside the healthcare facility are collecting a lot of data. Another program called WASN also is collecting data. So every single department in the hospital may be included in the process of data collection and analysis to do improvement. So what's data? Data are symbolic representation of figures, quantities, variables, or facts. If we have just only variables, facts, numbers, figures, we will call them data. Another definition is uninterpreted observation or facts. We did not do interpretation for them yet. It's still raw materials. Data are simply facts or figures without context or interpretation. I'll give you one example here for data. Someone is coming to you as a head of department, medical director, hospital director, and they told you that we have 100 females came to our hospital yesterday. This is a data, 100 female. But what the kind of those female, what did they do inside our hospital? It's good or bad? We don't know. So 100 female is a data. Let's go for the second concept, which is information. Information is attributing meaning to data. Add meaning to those data is an information. Using data such that they take on meaning, for example, by means of data comparison. If you compare those data, if you analyze those data, it will have a context that time. It have a meaning that time. So it's not true. It will be cocked. We call it cocked data or interpreted data or observation. We can call it right now information, not data. Data transformed through analysis, interpretation into a useful meaning for decision making. So data, we will transform it to information. That time we can help the leaders to take decision. Information refers to useful or meaningful pattern found in the data. What's going on through those data? It's the information. The same example of 100 female, but here with little analysis, all giving a context or meaning for the data. 40 of the 100 came for delivery, 60 came for OPD. Now it's an information. We divided, we split, we analyze the 100 female into 40 came for delivery and 60 came for OPD. That time we can take decision about the staff number, the instruments, the machines, everything about the department we can discuss because we know how many go for what kind of services. So what's knowledge? Knowledge is what enables a person to fulfill certain tasks by selecting, interpreting, and assessing information. If we put the human knowledge or human factor or human rule in those information, we can change them to knowledge. And always the knowledge needs the human experience, human part, or even IT. We will do more intensive analysis. We will do benchmarking. That time we can call it knowledge. So the knowledge is the capacity that enables a person to perform a certain task. And we have an equation. The equation is K equals I multiplied by ESA, while K is knowledge, I information, ESA experience, skills, and attitude. The same example is 40, we have 40 came for delivery. 20 of them, which means 50% of the 40 have cesarean section, while the benchmark is 25%. So we are doubling the benchmark for cesarean section. We are exceeding the benchmark by 100%. It's supposed to be 25%, but in our hostel it's 50%. So we have to do something with knowledge. So the pyramids of data is the initial part. We will change it to information. Then it could be changed to knowledge. Through this knowledge, we have understanding of the process or situation. Then it will give us a wisdom. That time we can take a decision or help leaders to take decisions. What's aggregation? It's something we will do with the data so we can change them to information and knowledge. Aggregation means combination. Combining standardized data or gathering data into a mass sum or all. So this is aggregation. So what's analysis? Analyze means separation. We will separate the substantial whole into frequent or into constituent parts of individual study. So aggregation means gathering and analysis means separation. The translation of data collected during the monitoring process through aggregation and interpretation into information that can be used to change process into improve performance and improve performance. Sorry for that. What's the kinds or types of data and information? We have two types, qualitative and quantitative. Qualitative, we are describing them. It's words, but quantitative is numbers, measures, or figures. Qualitative like perception, like opinion, like interpretation, like conclusion. But quantitative, I can give you some examples about quantitative, which is only numbers, like patient demographic data, like hospital acquired infection percentage or number or ratio. Comparative data with numbers, all of this are considered as quantitative. Also financial data and information. So the initial types of data are qualitative and quantitative. Here it's a very important slide which is talking about types of data in details. We have quantitative data, categorical data. The quantitative, we are talking about numbers, about quantity. We can divide them into two types: continuous data and discrete data. Continuous means we can use decimal. Examples: blood pressure, height, weight, age, the number of days from surgery to discharge. Number of days could be 2 days, 2 days and 2 hours, 2 days and a half. The same age could be 30 years, 30 years and 2 months, 30 years and 2 months and 5 days. So we can use decimals. But the secret, we can not use decimals. Like number of children's. Children's are 20 children, 21, 22, but we cannot say 20.5 or 20.3 or 20.7. So this is the first type, which is quantitative, divided into continuous and discrete. What about the categorical or the qualitative data? We are classifying them into ordinal and nominal. Ordinal, this means we can put them in ranks, in order. Something is better than something. Something is higher than something. Examples: grade of breast cancer, grade 1, 2, 3. Of course, grade 2 is much worse than grade 1, and so on. Better, same, worse. Disagree, neutral, and agree. All of this, we can put them in a rank or ranking, so we call them ordinal. But the nominal is, we cannot put them in rank. We cannot say something is better than something. Like sex, male or female, alive or dead, blood groups, color of the eyes, marital status, married or not. All of them is yes or no, one or two, something or something. So we cannot put them on rank because we cannot know which is better than the others. So those are simply the types of data. Okay, now if we are going to collect data, we have to have a data collection plan, data sources, team will collect data, tools for collection of those data before starting to do the analyze and interpretation. So when you are going to use data collection, you have to define or identify a problem, what you are going to measure, what kind of problem or opportunity inside your healthcare facility you're going to measure. To measure current function, we can use data to know what's going on, to monitor progress, to know what's upgrading, improving, changing, to measure the effect of a change. If you implement some changes and you want to know that the changes is effective or not, succeeded or not, you have to collect data again. General consideration while you are collecting data: choose a strategy is determined by the most effective, most feasible, and the most efficient mean. When you're going to collect data, you have to choose simple ways to collect that. Effective means it will give you the desired outcome. What you're intended to do, you have to expecting a result as is. Most feasible means easy for people to do it. Don't choose a very difficult data to be collected. Something very difficult to find in logbooks or in internet or HIS or something. Search for something feasible for the team to search for or to collect. And the most efficient, try always to discuss the resources. Don't use a lot of resources while you are collecting data. Build on existing information and system. If you have system existing for data collection, don't cancel it and start from point zero. You have to build up on. Identify sources of information, from where, develop a data collection tool. Of course, you have to have a tool to collect your data on those tools. Again, you have to ask yourself some question. What will be measured? What I'm going to measure? What kind of information I have to collect? Who will collect it? When I have to collect those data? From where I'm going to collect the data? How I will collect those data? How much data I have to collect, all the population, or I should better use a sampling technique? How will the data be recorded? I will record it on a paper or in HIS. on an Excel or a Word, on a paperwork. What sampling scheme will be used, sampling technique? Where in the process will data be collected? I will collect all the data during the whole process, or only in some areas where I have to do improvement. Determine the proper timing of data collection. We have 3 types of data collection timing. The first time is prospecting or prospective. This is before the process started. I'm planning to do some new process or some new project or some new services. I have to collect data before it. For example, if I'm going to have a contract with insurance company, or I'm going to build a new service like a burn unit or chemotherapy unit or oncology unit, I have to collect data. How many patients I have, what kind of services they have to do, how many rooms I have to build, what are the machines I have to prepare for them. The second type is concurrent. Concurrent means during the process itself. Example, the patient is inside the hospital and I'm collecting data while the patient is here, like what we are doing now with COVID-19 patients. We are collecting the data about COVID-19 patients, what was the symptoms, what kind of treatment they took, what's the investigation for them, so we can have a very good baseline about this disease. And the third type is retrospective. Retrospective means after the service is introduced already. And the patient may be, example, the patient is not inside the healthcare facility anymore. I'm going to collect it from logbox or medical record or something. What's the advantage of every one of this one? As I told you, this one is for new process or new services or new department. Concurrent, the advantage is the patient is there, the process is going, I can catch anything wrong. Retrospective, I can control the time. I'm not in hurry to do it. Determine the frequency, duration of data collection. How many times you are going to collect the data and for how long? You will collect all data for all patients or only sample. You will collect it per shift, morning or evening. You will collect it every day in the month or 1 week or twice a week and so on. Select the appropriate person for data collection. The appropriate person means the one who will give you the correct idea. Don't force someone to collect data, otherwise he will give you a fake data. And you have also to train him. So training may be required. To whom you have to train whom, or examples of people should collect data and should be trained. Departments, clerical staff, service clinical staff, key functional area staff, health information management, quality management review, staff utilization management, and the case manager. All of those people can collect data and all of them should be to collect data. Organize and analyze data. After collection of the data, you have to do something. You have to cook them. You have to do something before introducing them to the decision maker. We can put them in a table or a graph. So tabulate results, calculate indicators, ratio, frequency, rates for choosing indicator within established time frame. And you are going to present them like by aggregation or separation, or you can use graphic representation or display for them. Put them on a graph. So after collection of data, raw data, you have to put them on a table. You can calculate something, rate, frequency, ratio indicators, or introduce them on a graph to the decision maker so they can understand them. They cannot go deep down through those data, just they have to know what's going on, so can take decisions simply upon facts, upon information and knowledge. Organize and analyze data. Identify the team or committee, department, individual responsible for aggregation, initial analysis, and the intensive analysis. What's the differences between initial analysis and the intensive analysis? Initial analysis, you just give me what they call a broad idea about those data. But intensive, you have to give me root causes. You have to give me a deep view about the information. Perform at the designated time interval. Display the data appropriately, table or graph or KPI ratio or rate or anything else. Design data storage and retrieval system. Tell me where you have to put your data. You have to put it in a logbook, on a paper, on an Excel sheet, on a Word, or on HIS. How can you get this data again when you need them? This is the meaning of retrieval. Retrieval means how can I take them back when I need them? Communicate and feedback. This is our shortage inside healthcare facility. We will collect data, we will do some processes on them, then we will keep them. We'll do KPIs, we will keep them. You have to give feedback to those data to two levels. Level one, the departments and the area from where you collect data. Tell them what's going on in their departments. And the other one, you send them to the leadership group so they can take a decision, like committees, like governing body, like executive committees, like the medical board. You have to give them those data and information and keep tables and graphs. How can we display the data? Through data display tools. I'll mention here 4 types of data display tools. Number one, frequency of occurrence. You can put them on a bar chart, pie chart, or Pareto chart. You can put them on a trends over time, like run chart, control charts. Distribution, like box plot and histogram. Association, correlation, like scatter diagram. This is the bar chart. You put the frequencies or the data elements over time on a graph, on a bars, columns. How can we do them? Simply by Word or by Excel sheet. Both in 2 columns, the frequencies, the data, and the frequency, how many times it happened, or rate, or ratio, or percentage. Click, insert a diagram or chart, select bar graph, it will give it to you. So what about bar chart? The only difference between pie chart, the only difference between bar chart and pie chart is 100%. And its division inside the 100%. As you see here, 45% 0.4, 35% 0.7, 9.3, and so on. What's this? 45.5% is Hispanic peoples. 35 plus is the white people. The green is the African American. The pink one is the American Indians, and so on. So the only condition here is the total of those population should be 100%, and every population of them will take a rim of the circle itself. What about trends over the time? You have to use run chart or control chart. This is a run chart. Runs means it's running, so you will put the frequencies here against time. So the horizontal will be time and the vertical will be the data elements. Both the data elements against time when it's occurring, you will find it connected the dots with a line. It will give you a run chart or line chart. Then the control chart is a line chart or a run chart with an upper limits, control limit, and lower control limits. Beyond those limits, you have to investigate. I'll give you one example. You're coming from home to work in 7 minutes, in 6 minutes, in 10 minutes, in 7 minutes, in 9 minutes, in 8 minutes, and so on. So the total is between 6 minutes, for example, and 12 minutes, for example. You will never come before 6 minutes, or never you will come after 12 minutes. If you come before 6 minutes, we have to search why. You got a new car, you came with an aeroplane, there is something happened. Maybe good, maybe bad, but we have to search. If you came after 12 minutes, so you crossed the upper control limit, so you came very late. Why? Your car is stuck down. Maybe you saw an accident or practiced an accident in your way. Maybe you have a lot of traffic closed on you, or there is a flood. Something wrong happened, it makes you come very late. So this is the difference between the run chart and the control chart. What about box plot or and the histogram? Histogram simply here is the elements. You will divide them in 3 standard deviation, positive and negative. As we discussed before, when you're coming from your home, you will come between, again, 6 minutes and 12 minutes. And all other data is in between. After the tails here and here, those are the extremes outside 3 standard deviation. This is the scatter diagram. It will show you correlation or association or relationship between two data elements. One example is aging and cancer. If you have a theory that the cancer is increasing with age and you want to estimate it's right or it's correct or not, put them on the correlation or scatter diagram. If you find that they are increasing with each other, this means that the more the age, the more the cancer cases will come. Or maybe they are decreasing with each time. The little the age, the little the frequency or the possibility of cancer. So if you find them one line up or one line down, so there is a correlation or association. If you find it scattered, one dot here, one dot here, one dot here, one dot here, so this means no correlation. There is no relationship between the two data elements. So where is the potential quality data sources? From where I can get my data inside the healthcare facility, we have internal sources, we have external sources. Internal sources like what? Medical record, OVR summary, ongoing quality control KPIs, patient and staff surveys and questionnaires, direct observations, clinical reports from pharmacy, lab, blood bank, etc., infection control reports, demographic data, indexes, logbooks, registers, medication records. Again, we have from operative or other procedures, medical record, I can take it from it, medication usage, blood and blood component usage, pharmacy and therapeutic function, mortality reports, lab results, and with photography. Again, we can take it from KPIs, from risk management and claims, from utilization management reports, from safety reports, from financial reports, and from survey data. There is external resources of data. Yes, I can get some data from outside my healthcare facility. Like what? Like references database internet, accreditation reports from accreditation bodies, MOH inspection licensures, KPI, third party like insurance companies, researches and literatures, clinical protocols, guideline pathways, state, regional, national rates and thresholds, CDC comparative report cards. So those are the sources of data I can get from. What's the types of data collection tool? We can collect data on some tools. Examples, data sheet or worksheet. It's a form for recording data, requires subsequent processing for analysis and interpretation. We have to only collect data on them, then we can do the analysis later on. Check sheet, just you will put a check, then you will count how many checks in every item or in every element, so you can say this one is better than this one, or this one much worse than this one, and so on. Logs, the logs are chronological. We have to arrange the event inside the logs on a chronological manner. For example, 3 o'clock, we have a patient of bronchial asthma. 3 o'clock, 10 minutes, we have a patient with angina pectoris. 3 o'clock, 15 minutes, we have a patient with sickle cell anemia, and so on. So you cannot put 2 o'clock after 3 o'clock. So 3 o'clock after it should be something more than 3 o'clock, and so on. This is an example of data collection sheet, and this is an example of check sheet. You have to put only checks. We have survey. Survey, we have to give a questionnaire or a document containing some questions, and someone have to answer them yes or no or by numbers. So at the end of the survey, we should have some informations. We have interview like focus group. We will collect some people, we will sit with them, we are asking them about their opinion with open-ended questions. They will give us a lot of information. Indicators also, we can have indicator cards and collect the data on those indicator cards or indicator collection sheets. This is an example for the questionnaire and survey with focus group, and this is an example of the indicators. Let's explain each one of them simply. Check sheet, agree on the data, what kind of data you're going to collect, decide who will collect it, select the sample size, you will collect the data from every single patient, for example, or from patient coming in the morning or afternoon, or OBD or 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 ER, and so on. Trust the indicator, put your indicator, design the check sheet, test the sheet before using it, distribute the sheet to people, then collect the data, then evaluate it after collection. Check sheet procedure: decide what kind of data, what kind of problem you have, develop operational definition of the data. I will collect data in the morning from people coming to OBD who's satisfied with our services or waiting time according. Decide when data will be collected, morning, evening, what kind of shift, how many days per week, how many days per month, how many weeks per month, how many months per year, and so on, or all the time, all the hours, all the day, all the week. Design the form. Set it up so that data can be recorded simply by making checks or marks or X's or similar symbols, any symbols you need, and so that do not have to recopy it for analysis. Label all spaces, don't leave blank spaces. Test the check sheet for a short trial period before implementing it on a big scale. Check sheet can be used for a variety of purposes. I can use the check sheet for what? To trigger discussion of performance, to search for key causes, to measure the results of solutions or improvement, and for ongoing monitoring. Like percentage of number of nurses absent during different shifts. Take your cheat sheet and ask who's there, that nurse, that nurse, that nurse, and this nurse is not there. So one nurse is not here. So put a check sheet for one nurse. Another department, 2 nurses. Another department, 5 nurses. So at the end, you have 8 nurses are not present right now. The percentage or number of complaints per day of the week. How many complaints today? We have 2. Tomorrow we don't have. After tomorrow we have 5. So you can collect it at the end of logs. What are logs? Logs are simple. We said that chronological recording of the data and the information. And we can use logs for every single department in the hospital as soon as we don't have an HIS. And I think all of us are familiar with the logbook. This is a logbook. We have to put the time, the course, the log ready, wind speed and direction, latitude, longitude, and so on. So you have to consider that one row is one item of information. For example, in the hospital, one row is one patient. Patient ID, patient name, patient demographic, blood pressure, temperature, diagnosis, length of stay, discharging plan, medication. So this one is considered as a log. What about interview and focus groups? We will make a questionnaire format, can be open-ended. It's better to be open-ended question, like, what do you think about our services? The patient or his representative or the family will give you a lot of information. But if you make it closed-ended question, like, do you like our hostel? If he said yes or no, what kind of information you have? You don't have. Only clue idea that he don't like your hostel. But what kind of things he doesn't like, you don't know. But if you put open-ended question, like, what do you like in our hostel? He will tell you, I like how nursing treating us, I like the medication, I like it's clean, I like the food come to us hot, I like, and so on. So he can give you a plenty of information. Focus group is powerful information for gathering technique that causes small group discussion to identify the view of the people in the group about a certain subject. We have to have a facilitator, and he should be a skilled person. He can discuss the people, he can take information, should be very clever one. Focus group work best when questions are open-ended, as we said. If you want to conduct a focus group, doesn't require extensive training. It's important to follow established guideline, introduce yourself and introduce the problem and introduce people to each other. Give general introduction about the problem and what we are going to do, establish a ground rules, and conduct the discussion. Focus group should be between 5 to 12 individuals, no more than this, so we can control them, and it should take around 60 to 90 minutes, not more than, because people should focus with you, other than if you pass the 90 minutes, they can be not concentrating with you, fully conscious with you. The facilitator can be someone in your department who is good listener, he have to listen to people, is viewed as being open-minded, fair, good with people. What about surveys? Surveys are written questionnaires used to collect quantitative data. We will put some questions inside a form. We will give it to people, ask them to put their opinion, collect it again, and start to analyze data coming from them. Surveys are quantitative devices for collecting feedback to enlighten decision makers. They are useful for soliciting perception of customers when you want to identify reliable trend and pattern for large number of people. So I cannot meet all those large number of people, so it's better to give them a survey. Surveys are a method by which we can measure customer satisfaction, get feedback of them on written material or oral presentation. Example, we are doing patient satisfaction survey or staff satisfaction survey. How to develop a survey? Know your audience, who are your people, who are your customer you want to listen from or to get their opinion. Remember who will be answering your survey and imagine how they might interpret the question. So put a very clear question to them. Case rule is keep it simple, short. People tend not to answer the very long question and long survey, so put only 5 to 10 questions. Be direct. Ask exactly about what you want to know. Don't make it circles and don't make people hesitate. Make your statement or question neutral. If you state your question in a negative manner, you will get a wrong information. Thank you very much for part 1 data management. Inshallah, next presentation will be about data analysis, data interpretation, and so on. Thank you very much. Until we will meet in the next presentation. Assalamu alaikum wa rahmatullahi wa barakatuh.